So welcome to London Business School Wheeler Institute of Development COVID-19 series. Today we are pleased and honored to have with us Oendrila Dube joining us from Chicago, Illinois. Oendrila is currently the Philip Pearson Professor of Economics at the University of Chicago at the Harris School of Public Policy. She is a leading scholar in political economy and development. She has done some path-breaking research, among others examining the origins of conflict, examining what is the implication of having a king or a queen running the country on international warfare, but most importantly, given our focus and the focus of the international community nowadays on COVID, she has done some path-breaking work examining the effect of the Ebola crisis back in 2014 on the health system in Sierra Leone. And we are more than happy to have with us today Oendrila discuss about these findings. So, Oendrila, my initial question is that the title of your very cool paper is Building Resilient Health Systems, which is something that, we want to do in Greece, we want to do in Chicago, in Boston, in London. So why don't you tell us a bit about your work and how you approach this issue, of course, in the setting of Ebola in Sierra Leone. And thanks again for joining us.
Thank you, Elias, for the kind introduction. It's really a pleasure to be here. So I have some slides that I would like to share to provide an overview. So the starting point for our project was really the canonical observation that many developing countries faced really high rates of mortality. So in more than 36 countries, more than 10% of the population died before reaching their 5th birthday. And the low utilization of health systems, the lack of use of existing clinics stemming from fairly low quality of care in many of these institutions actually contribute to this negative outcome. So what we wanted to do is we wanted to ask the question, can improving health system accountability, that is holding health workers more accountable in these types of clinics and institutions, improve health services and health outcomes? So how did we do this? Well, we were working in Sierra Leone in 2012, and we randomized 2 health system interventions that were aimed at holding health providers more accountable. The first was a community monitoring treatment in which we brought community members together with clinic staff, and community members would levy complaints against the health services provided, and the clinic staff in turn would levy complaints about community members, and then the 2 of them together would hash it out and come up with a joint action plan for improving outcomes. So this was meant to provide greater oversight of the clinics. The second was a non-financial awards intervention in which we facilitated competitions between clinics and tried to motivate better worker effort by giving awards to staff at clinics that were performing very well. So we were going along, it was business as usual, we were doing our RCT, and then we had a surprise. About a year after we completed our end-line surveying for the project, the West Africa Ebola epidemic broke out. So we went back and we collected additional data on Ebola-related outcomes, and that really gave birth to 2 phases of this project. In the first phase, we're looking at medium-run outcomes under business as usual conditions during normal times about a year after the interventions were put into place. And in the second, we look at Ebola-related outcomes about 2 years after the interventions. Now, this was obviously unplanned, but it did present a unique opportunity for us to be able to examine experimentally the effect of these accountability type interventions on epidemic outcomes. So our evaluation design unfolded in the following way. We worked with 254 government-run health clinics in 4 districts of Sierra Leone. We randomized each one either into a control or into a community monitoring or NFA arm. And to measure outcomes, we surveyed households residing in the catchment areas of these clinics, surveying over 5,000 households in total. So what did we find? Well, what we found is that these interventions fairly quickly produced immediate benefits. So over the medium run, the interventions increased the use of health clinics, that is, increased clinic utilization. Not only that, but patients were more satisfied with the care they received and with health worker performance. And in fact, it transformed the beliefs in the relative effectiveness of Western medicine. So people residing near these intervention areas believed more that Western medicine was efficacious relative to traditional healers. And what we saw, especially in the community monitoring arm, is improvements in child health outcomes. So for example, we saw that there was a 38% reduction in the likelihood of a child under 5 dying in the households in these areas, which is a large effect. Overall, our takeaway is that these results suggest that these interventions really improve the perceived quality of care and confidence in the health system. So what about in the second phase, when we looked at the Ebola-related outcomes? Well, it's worth just noting that even in the beginning of the Ebola crisis, the World Health Organization was already describing the Ebola outbreak as one of the most acute public health emergencies. They said never before had a level 4 pathogen infected so many people so quickly over such a broad geographic area and for so long. And that was just in the beginning. By the end of the crisis, the CDC reported 28,000 cases and 11,000 deaths, with Sierra Leone accounting for about half of those. So as with other infectious diseases, the key to containing Ebola is early isolation and treatment. But the problem was that fear of substandard care and stigma really prevented people from coming in and reporting. People thought that if they brought their loved ones in, they would be completely neglected and left to die alone. And so when they got sick, instead of bringing their family members into the clinics, they would hide them or they would run away themselves if they were showing symptoms. But of course, what we had seen in the medium run is that the places where the community monitoring and NFA areas interventions had been put into place, there had actually been greater confidence and trust built up in the health system. So we wanted to examine in these areas, was there actually more reporting of Ebola cases? So in order to look at this question, what we did is we matched our data from the experiment to individual Ebola case records from the CDC's database. And using that approach, what we found is that there was substantially more reporting of Ebola cases in the NFA and CM areas relative to the control areas. You can see this in this figure. The dotted line are the control areas and the diamonds and the triangles are the treatment areas. Our interpretation of this is people were more willing to come forward and report and get tested for Ebola in the clinics in the areas where the interventions had been put into place. Now, of course, we had to address the possibility and rule out the possibility that this increase in reporting actually reflected increased transmission in treatment areas, and we have a number of ways we do that. So importantly, we find that there's an increase not just in reporting of confirmed cases, but also those who ultimately tested negative for Ebola with no change in the ratio. And we have some data from contact tracing that allows us to rule out the possibility that there was actually higher contacts outside the home in the treatment areas. Ultimately, what we observe is that death out of Ebola caseloads was actually about 33% lower in the treatment areas. So this is consistent with the idea that more testing facilitates treatment and care. And so overall, these interventions really improved Ebola patient outcomes in these areas. So what we take away from this is that the accountability interventions really have the power to build trust and confidence in health systems in ways that are beneficial under business as usual conditions, but also in ways that become critical during health crises. During crises, people are choosing whether to cooperate with response efforts by either complying with quarantines or volunteering for medical testing. And so this is exactly when views on the government and government health systems can prove particularly consequential for the decisions they make around life and death.
So thank you, Angela. This is super fascinating evidence and couldn't be more topical. So I find it super fascinating your result that an intervention that you could design was so hugely important in both reducing fatality and at the same time increasing the willingness of people to report on their health, which are both key aspects nowadays. We want more and more people to get the test, to be careful, and at the same time, we're hoping that this will reduce the mortality of COVID. So my question is, How should we think today, given your findings from your work about COVID, let's say in Africa, which is an area that at the Wheeler Institute we are very emotional about, and more generally in, let's say, low income and frontier economies?
Yeah, I think there's two key takeaways. The first is that testing saves lives and does this by facilitating early treatment and early care. So having enough tests is critical, which has been a real challenge in the COVID-19 crisis. But even if we secure the tests that we need, on top of that, it's essential to make sure that they're used appropriately and people are willing to use them. So particularly in the developing world, where the quality of the health system might be very low, it's important to take as many steps as possible to make sure that people are willing to engage with the health system, that people are willing to go in and to test where tests are available and to seek care. One of the takeaways from the Sierra Leone work is maybe having community involvement and greater community engagement could be a key to this. Where you have communities more engaged with local health providers, that's where messages about appropriate policies like social distancing and staying at home or getting tested and seeking care might resonate more with local community members.
Yeah, so let me jump on that. So we know from research that community engagement, civic capital, as economists call it, or social capital more generally, is associated with good outcomes. So can you elaborate on your setting, how exactly you managed to build this level of trust and civicness in Sierra Leone?
So the way in which the interventions operated, especially the community monitoring intervention, where we saw very large effects, is we would bring community members and clinic staff together through very large community meetings. And the starting point would be really presenting a scorecard where we gave some basic information to community members about what the health problems were like in their locality relative to other localities in the country. So we would focus on statistics like maternal and child mortality. And this would galvanize a conversation about why are these statistics, why do they look as bad as they do? And this would open up the door for a discussion where people would raise complaints. Like they would say, why is the nurse never actually present when we go into the clinic? Why does she yell at us instead of listening to us when we're trying to describe what's wrong with our kid? Now, the facility staff in turn would also have some issues that they would raise with community members. The nurses would say, we can't help you if you don't come into the clinic. They would say to the women, you have to come in to deliver your babies in the clinic. If you're delivering your babies at home, we can't help you there, right? And so these types of issues would be raised. And this would happen through 3 iterations of community meetings. And at the end of the period, the community members and clinic staff would work together and they would develop these joint action plans where they made very specific concrete commitments on the types of things that each side would do to try to improve these outcomes. So that's the way in which we really were stitching together community members and clinic staff and getting them to embark on some shared goals.
I heard you saying trust, people believing that the nurses and the doctors are there for them to assist them, also trust in the delivery of health. These are issues that almost surely are more salient in Sierra Leone as compared to Sweden. But I would say that there is a lot, there's a lot of these issues are present also in industrial countries, in the US to a great extent, but also in Europe. So clearly it's always hard to extrapolate from research, but what are your feelings and your thoughts about the implications of these findings about industrial markets, industrial countries, which I understand the language is not very good, but let's say G7 countries?
Yeah, absolutely. So obviously the US is not Sierra Leone, the UK is not Sierra Leone, but there are some shared challenges that are common to all countries that are facing epidemic outcomes. And I think distrust and the lack of trust is one such common element that we're seeing in the context of the COVID-19 crisis. Now, the nature of distrust might be different. It may not be rooted in perceptions of the low quality of care in the developed world. But one way in which the distrust has been manifest and played out in the developed world is, some people have been very skeptical as to whether COVID-19 actually presents a threat to themselves or to other people that they know. What's interesting is in the US, that perception of whether COVID-19 is a threat and poses a threat varies a lot based on partisan affiliation. So polls have shown repeatedly that Republicans think COVID-19 is less of a threat than Democrats do. And what's interesting is when the Ebola crisis happened in 2014, and at the time we had a Democrat president in the US, Democrats considered the Ebola to be less of a threat in terms of potential spread than Republicans did. So this is very telling because it's telling us that it's partisan affiliation and ideology rather than trust and belief in what health officials are saying that is guiding how people view the epidemic. And that can be hugely consequential for whether or not they're willing to take steps to curb the epidemic, like whether they're complying with social distancing or stay-at-home orders.
Yeah, I think it's fascinating. Actually, in our discussions in later weeks, we will try to delve onto some of the issues that you raised. If I was to take now, and here we also want to be a bit more practical, which is not always the case, at least with academics, although clearly the work that you're doing is very practical. So I'm more criticizing myself here. The question is, given the low levels of trust in healthcare delivery in emerging markets and frontier economies, or distrust in the political system, let's put it this way, that seems to correlate with also distrust on various social distancing policies that we see in industrial countries, how can we think about leadership? And how can we think about changing the perceptions without having the luxury of doing an intervention where we bring people together for a year?
It's a really great question. And here I really believe in the dual approach. So I think that it is critical to have clear, consistent messaging rooted in science from our national leaders and public health officials that articulate what it is we should and should not be doing. But what we have seen is that this isn't always enough. We really need trusted local voices to amplify these messages to get people to view things as a threat or comply with these policies. So what do I mean? I mean, there are lots of local community organizations that work on a plethora of issues. They can inject their voices into reinforcing some of their critical health messages. I'm talking about celebrities and athletes, people who other people look up to. I'm talking about religious leaders, right? So interestingly, in Sierra Leone, in West Africa, during the Ebola crisis, religious leaders, both Christians and Muslim, came together to articulate very critical messages about burial practices and changing burial practices, which were a source of spread of the disease. And this had a huge effect in terms of turning the trajectory of the disease around because people really looked to these faith leaders. And I think there's a lesson there also for the developed world in terms of having these types of leaders play more of a role in injecting their voices into the mix.
I think you put it eloquently. I couldn't agree more with that. So my last question, and actually this relates a lot to the vision of Tony and Maureen Wheeler, who founders of Lonely Planet, who very generously endowed LBS to pursue a lot of research and teaching on the intersection of business and development. How can we think about the role of business, both in the case of Sierra Leone, but also today if we were to think about Africa, and how hopefully Africa suffers the least from the looming crisis related to COVID, either directly or indirectly?
So, the private sector has played a critical role in a couple of different dimensions in these types of epidemic contexts. One that we were just discussing about these types of campaigns that local leaders can embark on. So if you think about broadcast companies and media outlets, they have played critical roles in amplifying some of these messages. Broadcast companies were critical in televising a lot of what these religious leaders were saying about burial practices through televised campaigns, which was an essential element. Now, if we think about the COVID-19 crisis, the large role that the private sector has already played and will have to continue to play is in drug development and in treatment, right? So the diagnostic testing was developed by various pharmaceutical companies. Obviously, bottlenecks remain in terms of having enough of those tests, but the development of those tests was critical. The other, large component going forward is going to be serological testing. Right now, we're not quite there yet. The serological tests that test for whether there's antibodies in your blood, which is going to be a critical factor in getting people safely back to work, have high rates of false positives and false negatives. And so there's a lot of room for improvement there, but it's going to be the private sector that, hopefully embarks on better testing and development of better tests. And finally, on a more optimistic note, in terms of vaccine development, there's over 70 companies that have been involved already in vaccine development, and 5 are already in phase 1 clinical trials. So it's going to be a year before we have a definitive answer, but I think that's a very hopeful note for envisioning a world free of COVID, hopefully very soon.
So I really enjoyed this positive and attitude and optimism in the end. So Andrila, on behalf of the Wheeler Institute and London Business School, I want to express our gratitude for taking the time. Your work is super fascinating. I urge all of those who are watching us to have a look at the details of the study. They are truly fascinating, and they carry a lot of lessons, both for those who care about African frontier economies, but also to understand more about these issues about the rich club of nations. Andrila, thank you very much for taking the time, and we look forward reading more and more of this line of your work.
Thank you
very
Elias.
much.
Thank you. It was a pleasure to talk with you.
Thank you.